Hi, I'm Brian Berman, and I've been asked today to discuss superficial radiation therapy for the treatment of keloids. These are my disclosures, and I will be discussing off FDA usages. What's the clinical problem? Well, on the left-hand side, there was a keloid, which we excised and sutured up. We thought we did a pretty good job. But unfortunately, a year later on the right-hand side, the keloid recurred. And that's the bad news. The worst news is that, as we know, when keloids recur after keloidectomies, very often they come back larger than the original keloid. Now, I hope this never happens in your practice, but indeed, if you look at the literature, keloids recur 71% of the time after keloidectomy. So it's a big problem. Let me introduce you again to X-rays. X-rays with a wavelength of 10 to the minus 10th meters is just to the right of ultraviolet light in the electromagnetic spectrum. And X-rays are able to transfer their energy to RNA and DNA, causing splits in the backbone as well as the crosslinks in the RNA and DNA. In addition, X-ray can transfer their energy to water molecules, and then the high active water molecules are able to cause breaks. The bottom line is you get double-stranded and single-stranded breaks in the RNA and DNA. And I think we all know that skin that's been irradiated with X-rays has delayed wound healing. And this is due to radiation inducing cell cycle arrest of fibroblasts, as well as inactive fibroblast proliferation, and therefore delaying wound healing. Also, radiation induces greater apoptosis of these fibroblasts, which is natural programmed cell death of the fibroblasts. Now, that's for normal wound healing, but maybe judicious use of X-rays may be able to reduce the excessive wound healing that occurs with recurring keloids after keloidectomy. And indeed, Cal and al. Were able to identify the optimum biological effective dose, the bed dose, of superficial radiation therapy to reduce recurrences after keloidectomy. And that is a value of 30 gray. Now, that could be achieved by a number of dosage patterns, but the most common is 3 fractions of 6 gray on postoperative day 1, 2, and 3. So a patient walks into your office with a keloid, you can excise the keloid, suture it up, and then on postoperative day 1, 2, and 3, irradiate the suture line and a 5 millimeter margin with superficial radiation therapy with a biologic effective dose of 30. And here 6 months later and 12 months later, a very nice cosmetic result post-surgery with no recurrence. We then undertook a questionnaire survey of 297 keloids that were completely excised, starting on postoperative day 1, the suture line and the 5 millimeter margin were exposed to a biologic effective dose of 30. And the percent of patients that had recurrences was 3% of the excised keloids recurred. Now, this study was a survey study and it included some relatively short follow-ups. So we then undertook a more formal study, which was a retrospective chart review study of 96 excised keloids that had received superficial radiation therapy after the keloidectomy and had at least a 1-year follow-up. Again, 3 postoperative day 1, 2, 3, biologic effective dose 30, 6 gray fractions of superficial radiation therapy was applied. And at 12 months, the rate of recurrence of these keloids was 10.4%. It's important to note that only half of the recurrences, 5 of the 10 recurrences, were clinically insignificant, and only 5 were significant recurrences, but all were included in the 10% recurrence rate. The other good news was going another 6 months out for follow-up, only 1 additional recurrence occurred during that period of time. And using Kaplan-Meier survival probability estimates, a cure rate of 85.6%, that is, no recurrences, from 24 months post superficial radiation therapy treatment onwards. It was interesting that if the keloids were on the chest, there was a greater recurrence rate. But the good news was if a patient had multiple lesions of keloids and they were all excised, they all got superficial radiation therapy, if one recurred, it didn't mean the others recurred. In fact, they did not. So what's better? Surgical excision with external beam radiation, or excision followed up by true isotopic brachytherapy. To that end, a 10-year retrospective analysis was done on 264 excised keloids. Some of them were excised and just followed up. 197 of them received post-excision external beam radiation therapy, and 39 of them received the excision and then followed up with high-dose interstitial iridium-192 brachytherapy. The recurrence rate of those that received excision alone with a 9-month follow-up was 54%. 19% recurred if they had the excision but received external beam radiation therapy, and these patients had very long follow-ups, 42-month follow-ups. 23% recurred if they received brachytherapy at 1 year post-excision. No development of any malignancy is a very important finding because that is a concern. Ogawa and co-workers did a literature search going all the way back to 1901 through March of 2009 and were able to locate 5 cases of carcinogenesis associated with radiation therapy for keloids. And these were the tumors, most of them very common tumors, but the fibrosarcoma could be of concern. But it turned out the authors of that paper quickly admitted that in all likelihood, the original so-called keloid that was excised was probably a fibrosarcoma at the start. Also, the authors of this review said that it was unclear whether patients received appropriate doses of radiation or sufficient protection, again, going back all the way to 1901. The authors then concluded that radiation therapy is an acceptable modality for treatment of keloids, and this allowed for consensus guidelines to be developed regarding using the bed 30 on postoperative days 1, 2, and 3, fractionated at 6 gray, for the treatment of post-excision keloids. And they also noted that there was little evidence that exposing keloids or the surrounding healthy skin to SRT at the bed 30 causes any skin cancer. So when a patient walks in your office with a lesion like this on a Friday afternoon, you can excise the lesion, suture it up, and then immediately the next day getting superficial radiation therapy for 3 days in a row. And this patient did quite well. Well, how about if you don't want to excise the keloid at all? What's new for the future? Well, there's kynurenic acid, which is a metabolite of tryptophan, which increases metalloproteinase 1, as well as reduces collagen and is able to flatten scars in a rabbit ear scar model. 63 patients with mature keloids completed a randomized controlled comparator study being treated twice a day for up to 120 days with either the active FS2 cream, placebo cream, or onion extract cream as the active comparator. The good news, there were no adverse events and no significant local skin reactions were observed for any of the treatments, but the FS2 cream had significantly greater reductions from baseline in the patient graded score, as well as the Vancouver scar scale, compared to vehicle or the onion skin extract comparator. So I want to thank Marie Curie here in her laboratory in Paris, because I did a postdoctoral fellowship, not postdoctoral fellowship, it was my sabbatical in Paris in her laboratory. And I was assigned specifically to one of her laboratories, but I was assured that there was no radium in the laboratory. But I must say that I did have a full head of hair at the beginning of my sabbatical. I want to thank you for your attention and enjoy the symposium.